more of a fill-in topic because we had some other topics scheduled, and one was really looking at sociodemographic factors. So we decided that we wanted to keep that in there. Full disclosure, the direction I thought I was going in and the direction I ended up going in were slightly different. So, and this is my second, I did a cultural sensitivity talk earlier this week. So I was kind of immersed in some of the sociodemographic information. These are our CE objectives. These are the objectives specifically for this lecture. A couple things that we're gonna do. One is look specifically at prevalence information on patients who have opioid use disorder. We're gonna look at that and then relate it to some of the obstacles that really could hinder patients' ability to access medication-assisted treatment. In doing this, I use the National Institute on Drug Abuse. So a lot of the initial information is going to come from their national survey on drug use and health. And these are the abbreviations that they used and the categories that they had identified. So that's where those came from. And just for a matter of to try to keep it a little bit easier to read with some of the charts, I just included the key here. So I was a little, I got myself turned around as I was trying to develop this talk in general, and I kept coming back to these particular questions. And I think the who was the biggest thing that I was trying to look at. Is there a target population that we should be doing a better job on? If so, who would that be? So that was what led me to this national survey on drug use and health. So most of the data that I'm including is from the 2018 analysis. The 2019 data isn't completely out there yet. So in this survey, so it's a national survey that's done. They survey over 67,000 individuals and they ask a number of questions. But then based on that data, they actually take it and break it down in a few different categories. So these are the ones that they looked at. So a handful ethnicity-wise, then looking specifically at female patients, veterans, and those in the LGBT community. So this was looking at the number of individuals from each of these demographic groups that actually met criteria for substance use disorder. Now, this could be substance use disorder for any illicit substance, for alcohol, but I thought it was important to look at the variability across the different groups, seeing that in some cases, it was relatively modest. It reported at 10%, while in other groups like the LGBT community, it was identified at almost 50% of the individuals did meet that criteria. The other thing that they had asked was they looked at mental illness and then individuals who had mental illness and substance use disorders. And again, there is a little bit variability, but between 5 and 20% did have comorbid conditions. So this could be something that would potentially, to piggyback off of what Dr. Delastreyes did this morning, this could be something that could be problematic for some of the patients and really be an additional obstacle for why they could engage in and then be maintained in treatment. So since that was just substance use, I wanted to narrow it down a little bit further for opioid use disorder in general. So globally, it's thought to be about 16 million patients. In the United States, estimates are about 3 million. With 2/3 of them being prescription opioids and 1/3 of them, my dog just got up and I thought she was going to jump in my lap. So I apologize that I jumped there because she's like 85 pounds. 1/3 of them being illicit opioids. Now, it wasn't completely clear if the illicit opioids also included some of the fentanyl products. It does look like carfentanil fit in there, but some of the other derivatives of fentanyl may have been in between those two. So about 2/3 prescription pain relievers and 1/3 being more of the illicit products. And this is consistent when they drill down and look specifically at heroin use and then just other opioid misuse, where you see the heroin use is less than 1% across the board for all of those different groups, but the opioid misuse is still pretty significant. So that means that a lot of it really is coming from some of those other products. One of the other things that struck me as I was looking at this data was the variability. So for patients of Asian, Native Hawaiian, and other Pacific Islander, um, so they were about 2% of patients with opioid use disorder, whereas the LGBT community was almost 10%. So in thinking about some of these groups, you could see where some could potentially get lost in the shuffle just because there may be a greater number that really need treatment in some of the other groups. I was interested in seeing, they did drill down specifically, recognizing that there were quite a few prescription products that were being misused. Now this data is a little deceptive, so I do want to explain it just a little bit. So they asked patients who had received a prescription for each of these medications. And then based on the number that were taking these prescriptions, how many of them were misusing them, so not using them the way that it had been intended. I did include the US overall, so for the general population, what percentage that was, and then the comparison groups are also included. I thought it was interesting, a couple things. So hydrocodone and oxycodone, probably not a huge surprise that those were some of the most pronounced misused opioid medications. There seem to be pockets of patients that are misusing codeine. So those of the Asian descent as well as the Hispanic, Latino, and Spanish origin, they tended to be more likely to misuse some of the codeine products as well. There were only 2 numbers given for patients that are misusing buprenorphine or methadone, and those 2 numbers were for the female patients only. So it doesn't necessarily mean that the other groups aren't misusing those, but that particular data was not necessarily included. So again, quite a bit of variety across the board, but I think also really emphasizing that there is significant misuse of all of these products. So the being able to address this directly and really open up treatment is going to be important, because these medications in general are not going to go away. They're not going to no longer be available on the market. So in recognizing that there are a significant number of patients who have opioid use disorder, they also reported the number who were getting medication-assisted treatment. So our first bar is that 3 million number. So the estimated number of patients in the US who have opioid use disorder. And I recognize not all of them should be on medication-assisted treatment, but I thought it was helpful for a comparison's sake. So in 2018, there was just over 1.1 million individuals that were receiving medication-assisted treatment. Of them, look at my percentages here, little over half, so about 55% of them were receiving one of the buprenorphine type products. Just under 40% were on methadone, and then just over 5% were on naltrexone. So 40% in general were on medication-assisted treatment at some point, with most of them being on buprenorphine type products. So I would venture that, again, not 100% need to be on MAT, but this does give us some room for potential improvement. So keeping that in mind, that we've got room for improvement, what might be some of those obstacles for patients actually getting on medication-assisted treatment? So this is obviously not an all-inclusive list. I wanted to try to keep this within a reasonable period of time. So here are some of them. We are going to look a little bit more in depth at both access as well as some of the financial considerations that may play a role. But each of these definitely could factor into whether or not somebody is enrolled and engaged in treatment. So looking at access, I switched over to the National Institute on Drug Abuse. They have a national survey of substance abuse treatment services. So they send surveys out to over just under 15,000 different facilities, and they get responses back. And this way they're able to track some changes in services that are provided, as well as where they're provided throughout the United States. So the good news is that there have been national increases in the number of substance use disorder treatment facilities across the US. So between 2017 and 2018, that number went up to by about 1,300. But just because that number went up, it doesn't mean that all of those provide access to medication-assisted treatment. Of the facilities that reported, about 10% offered methadone. About a third did offer, either directly or in relationship with a provider, access to buprenorphine, and just under 30% offered access to naltrexone. And I thought it was interesting, the trend data, this was the one figure that I did borrow. It's on a publicly available website. You can access it there through the hyperlink at the bottom. But even though the number of facilities is going up slightly, it's interesting that the residential, that pink bar, really isn't changing too much. The hospital values look like they kind of dipped and then came up a little bit. And the opioid treatment program, so those that can provide medication-assisted services, also is a little bit stagnant. So we're improving access overall, but maybe not specifically to medication-assisted treatment alone. Or in combination, I guess would be a fairer thing. So recognizing that we have more programs, but not all of them do offer this, do the programs that exist, are they able to address some of the concerns that potentially some of those ethnic or other groups may need? So they look at other services that each of these substance use treatment facilities provide. I thought it was good news that about half of the programs do have programming specifically for patients that have substance use disorder and mental illness, although I guess it could be argued that glass half full, glass half empty, right? That half of them aren't doing that, and we know that between 5 and 20%, at least of some of these groups, definitely need that. A third of them offer some assistance in programming related to criminal justice type issues. There are some that are targeted. It was about 20% for both elderly as well as for younger patients, adolescent type patients. Just under 20% for HIV and AIDS patients. There was even less than that for other infectious diseases. So for patients who had hepatitis, it was in the single digits for programming for them. The LGBT community, I did want to identify this one specifically. So 20% of the programs have programming that's targeted for some of the concerns that this population had. If you remember back to those first couple slides, the LGBT bar was one of the highest ones for opioid misuse. So there is definitely a high need in this population, and that may not necessarily be getting met in some of these treatment facilities. Interestingly, some of the language barrier considerations, so about a third of the places do have some sign language programming for individuals that may have auditory issues, and about half of them did offer services in a language other than English, with Spanish being the most frequent. So some of them are diversifying their programming. It could be said this is an opportunity potentially to continue to develop programming to meet the need for some of these other communities. I did want to mention for the translation services, despite the fact the American Indian and Alaskan Native group had a significant burden of opioid use disorder, the translation services for them was less than 3%. So that was definitely a population where you could see a discrepancy in potentially there being a language barrier of them receiving services and not be getting them in the language that they need. Related to that, so how about the money? Because money is what drives a lot of this. They asked each of the treatment programs about payments. So the accepted payments, this is the percentage of treatment centers that accept this type of payment. No surprise, cash and self-pay was accepted by 90%. I actually was surprised it was only 90%. I expected that to be higher. Then you can see most of the rest of them, between 1/3 and 2/3, did accept some type of combination of private insurance, Medicaid, other state health insurance, Medicare, or military insurance. It was interesting also that the diversity of payments that were accepted. It was noted that less than half, so about 45%, would allow treatment for a patient who could not afford to pay. So recognizing from a socioeconomic standpoint, some of these patients that may need to be engaged in treatment may not be able to afford this. But that would really limit the number of facilities that they would be able to go to. And most of those facilities ended up being government or not for-profit programs. So that still limited the number of services that would be offered there. I found it interesting that the private programs that tended to be for profit were the ones that were most likely to offer methadone. So if you were looking for methadone and it was more of a government run or not for profit organization, you may be less likely to be able to find that as an option for your treatment. So looking at all of those pieces and how it could potentially really make it more difficult, is that what's actually happening? So these are just the last couple things that I wanted to include, but I found 2 retrospective cohort studies that look specifically at insurance information. One was done in a younger population, one was done in an adult population. So this one I really liked just because the sample size was so robust. So it was over 9 million individuals that their insurance claims were screened. And they pulled out only those that were young adults that had a diagnosis of opioid use disorder. And what they wanted to know was, of those who got a diagnosis for opioid use disorder, how many of them received medication-assisted treatment within 6 months of diagnosis. So 0.2% of the sample had a diagnosis of opioid use disorder. A quarter of them, so 26.8, so just over 5,000 of those patients actually got a prescription for received either methadone, buprenorphine prescription, or naltrexone within 6 months of their diagnosis. Most of them did receive buprenorphine, but I think that argues that we do have quite a ways to go to be able to help, again, maybe not 100% need to be on it, but to close that gap for a number of those patients. When they looked at those that received treatment, they found that those that were older, so older in this case was 21 to 25, were much more likely to receive medication-assisted treatment than those that were in their teens, significantly more so when you got into the even 13 to 17 age range. Females were less likely to receive medication-assisted treatment than males, and individuals who were non-Hispanic Black or that were Hispanic were less likely to receive a prescription for medication-assisted treatment than those who were white. So again, looking at some of those differences, this time adding age is a consideration, we do see differences gender-wise as well as ethnicity-wise. All right, last slide, because I know they just turned the blower on. This was also a retrospective cohort, smaller sample size. So these were patients with an opioid use disorder, so over 340,000 patients that had this diagnosis. And they looked at those that were treated versus those that were untreated with medication-assisted treatment. And again, what they found was females were much more likely to be untreated than to be treated with, and it could have been any methadone, any of the naltrexones, or a buprenorphine product. Those that were younger still were less likely to be treated than those that were older. And this one was a national database that looked at over 100 different kind of subgroups of this insurance company. And they found that depending on where you live geographically made a difference. So those that were in the Midwest and the South were actually less likely to get treatment. I thought it was also interesting that as they followed patients, there were quite a few patients who did receive naltrexone, and those that were on either oral or injection, between 50 and 70% of them had discontinued treatment before their first month was up, as compared to about 30% who were receiving buprenorphine naloxone, who discontinued treatment in the first month. So even though there were more patients receiving some of these other treatments, yes, they were treated, but for how long really could be argued. So in summary, this was just a very quick high-level review of that there are some sociodemographic differences in patients who have opioid use disorder and may be able to benefit from medication-assisted treatment. And there's a lot of different factors that could potentially play a role, but patients who are younger, who are female, and those of African American, Hispanic, and I would argue even the American Indian, Alaska Native may be more likely to have access to MAT than other patients. And with that, I will turn it over.
Thank you, Dr.